Welcome to Perspectives, the vodcast of the American Mental Health Counselors Association with the National President and Interim CEO/ED, Dr. Beverly Smith. This vodcast will bring to you the perspectives of clinical mental health counseling as it pertains to ethics, public policy and legislation, multiculturalism and social justice, as well as leadership and advocacy. This vodcast will feature experts in the clinical mental health counseling field to enhance the work of clinical professionals and to inform the public. The American Mental Health Counselors Association advocates for over 130,000 licensed clinical mental health counselors in the United States who are licensed to assess, diagnose, and treat mental disorders. We are the only organization working exclusively for clinical mental health counselors. Join the Perspectives for insight from experts on wellness and daily living, current clinical research, integrative healthcare, as well as how to maintain personal, family, and organizational wellness in an anxious and ever-changing world. Let's connect and hear the perspectives.
Hello, and welcome to AMHCA's vodcast called Perspectives. I'm Dr. Beverly Smith, President and Interim CEO of the American Mental Health Counselors Association. Today, I have an awesome person with us, Dr. Judith Harrington. She is the chair of the AMHCA Advanced Clinical Practice Committee. She's a professor, she's a colleague, and she's just a wonderful person that leads by example, by just being a great leader, showing humanity, showing respect. And so I've enjoyed working with you, Judith. But at this time, tell us a little bit more about yourself.
Well, I will do that, but not without first thanking you, Dr. Smith. You have been a great president, lots of new ideas. This is a new thing. I love it. Thank you for everything that you're doing. I know it's just a huge commitment, and I appreciate all that you do. I teach at the University of Montevallo. I am the program coordinator and also the coordinator of the couples and family track. I have an LPC and do lots of supervision with LPCs 2B, and I'm also an LMFT in my state. I was in private practice full-time from about 1985 until 2013 when I began full-time at the University of Montevallo. So I always like to say I made a living full-time as a counselor. And that's, in the old days, that was really an important accomplishment, because to grow and build a private practice, at least in the old days, it took a lot of time and years to make that happen. I know that now it's very different because of largely the involvement of technology supported counseling and communication, along with the hastening of the pandemic to use those technology resources. But I was a 30-year volunteer, and sometimes I was a paid staff member at our crisis center in the Birmingham region, which serves over 5 counties in central Alabama. And as a part of that, somehow I ended up doing a suicide bereavement group for 14 years. And that changed my life into a diehard, that's probably not the right word to say, but a total committed suicide prevention advocate. And so I do a lot of suicide training, and I've been teaching 3 credit-hour courses at my university and at another university since 1988. I'm very focused on prevention, intervention, and postvention, which is where I got started with the bereavement group. And that led to, a deeper specialization in trauma, grief and bereavement of a general variety, and so on. So at my university, I teach the classes on crisis and trauma-informed counseling, grief and loss counseling, suicide, and a few other courses, but those are, for me, they're kind of like the heavy courses. And I love every minute of that, to be able to turn our counselors in training into effective responders, to people in all of those kinds of adversities. So I live here, and I'm married. I have one son who's 17, and life is good.
That's good. So you talked about your areas of expertise in the area of grief, trauma, and crisis counseling. In those areas where you serve and you give and you teach in those areas, what are some of the things you would say to our audience to be mindful of or to consider when you're talking about grief, bereavement, crisis, trauma? What are some of the things that maybe you even share with your students, or you have conversations with colleagues? What would you say to our audience in reference to those topics?
Yes, and they do go hand in hand together. When someone experiences trauma, there can be grief in the form of non-death losses. Sometimes there are death losses with fatalities, disasters, that kind of thing, but with other types of traumatic events, there is a loss of assumptive beliefs, a loss of security, a loss of the way that maybe we were trained to view the world, the way we were socialized. So they do run together. But one of the startling things, I bet a lot of our AMHCA members know this already, but if there are those who don't, as a nation and maybe worldwide, we've had a fixation with the wonderful Dr. Elizabeth Kubler-Ross. And when she wrote her book about the stages of grief, shock, denial, bargain setting, I think anger is in there. Let's see, shock, denial, anger, bargain setting, depression, and acceptance. She really wrote that book to address the process of dying. It was a book for a person who may be beset by an illness or anticipatory death. And so one of my relatives actually, had her as a conference speaker in San Antonio, Texas, and Elizabeth Kubler-Ross, who I adore, she told them, this is not what the model of those 5 stages were not intended for grieving the loss of another person. But I think our country was so hungry for a model that would just help in any way that there was a lot of, kind of like face validity to that. But nowadays we're understanding more clearly what she intended. And also we're having more research come about related to the lifelong process of grieving. And the models that I would point to would involve what I would call, like an oscillating fan, that sometimes the fan of our heart, of our grief, kind of moves to maybe more affective, emotional experiencing of loss. And then it might move in the other direction to, I have to do something. My husband has died and I can't handle this big house anymore. I've got to move, or back to sadness and yearning, and then back to, I have to adjust. I have to, this is my new identity, and it's more utilitarian or instrumental. So that whole approach to grief is something I would invite our members to stay current with. And there's a lot of good stuff going on. We don't think of grief as you go through these stages and then you're done. Really, grief is with us forever, but the magnitude of the grief experience lessens with time as we do, reorient ourselves with that new identity of having that loss in our story.
That's true.
And with trauma, obviously we have jettisoned ourselves into a trauma-informed culture of mental health professionals that is so significant. And I do know people that, colleagues that I know that don't want to get like, I think that they would say that trauma-informed people are kind of hyper-religious about it. But it is very important. It's very significant. And our understanding of brain science and the ability to do imaging studies to show us where depression shows up in our brain, where trauma shows up in our brain, the emphasis on neuroscience and, you know, the amygdala, polyvagal theory, all of that is really helpful to me anyway. But I would point to the CDC and their research with Kaiser Permanente and the adverse childhood experiences studies that are so important. For decades and decades and decades, we thought children would just be resilient and grow up and get over it and forget it. But we know now that children who experience non-single episode traumas, in other words, complex trauma at home, toxic stress, they are more likely to have psychiatric illnesses and other illnesses that might be, you know, along the lines of cancer, diabetes, vascular disorders, and that kind of thing. So when the insurance companies now understand this, at least from my point of view, I've seen so much more products, developments, initiatives that extend trauma-informed care to very, very young children. If I've got a booklet somewhere, traumatic experiences from 0 to 5, and we never would have had that before this research.
You are so knowledgeable and just a great source, a wealth of resources and information. And so I appreciate you sharing that. And just again, sharing your wealth of knowledge. You've always done it since I've known you. And so that's one of the things that I appreciate about you. When we talk about grief and trauma and talk about or consider the mass shootings that have occurred within our communities, how do we make sense of the mass shooting in light of or considering grief and trauma for youngsters, for adults, for just professionals and members, period, members of the community? How do we begin to make sense of all of this?
Well, it is so sad, and I really have to practice a lot of trauma stewardship in terms of how much of that information I take in a given day. I monitor my news intake. It's so disturbing what we have come to. I try to hold on to hope, but I know that, you know, grief happens and the traumatic experience. There's so many different types of grief and trauma that I think we're experiencing it right now at the collective level, at the national level, not unlike the way we all felt after 9/11 happened. And it was a palpable type of distress that even if you were 8,000 miles away from New York City, you felt it. And I have that feeling right now. And I have that feeling a couple of years ago when, you know, the racial reckoning conversation started to happen in the form of demonstrations, that it's a national collective type of experience. We know, and the DSM has just come out now in the DSM-5-TR, they have a diagnosis called prolonged grief disorder. I have a few thoughts about that I may not be in agreement with it 100% of the time, because I think it's prone for some people to pathologize someone who can't get over their grief like quickly enough, like whatever quickly enough means. And when we look at complicated bereavement, it's complicated for multiple reasons. It could be because it's an unjust death, it's an unsensible death, it's children, non-normative deaths. It involves complex myriad factors. We always have harder reactions to human-formed disasters than we do nature-formed disasters, because it seems so unthinkable. Why would another human do this to innocent people or anybody? And so for me, a person who has all of those complexities surrounding their loss, they should be able to take longer to grieve. It is more complicated. It's it's not just only loss, it's trauma, it's stigma, it's judgment, it's political conflict. And so when I think about prolonged grief, I have three images in my mind. One would be the image of a curb, like on the street, an image of a wheelchair, and an image of people crying. And the one picture that we need to hang on to the most is the wheelchair, because the wheelchair is an adaptive device that allows people to get up and over the curb, which are obstacles for people who are hurting. And to me, to give grievers a diagnosis as if they are not able, or as if they are disabled somehow, is a little bit unfair when you consider all the curbs in their life. They were just doing what good parents do, taking their kids to school. They were just doing what good parents do. You trust and partner with the teachers and the educators and leaders, and those are not pathologies. So I do understand that some people will be afflicted with prolonged grief, but I would like for counselors to look at the context of that and to give more, these would not be counseling techniques, but more wheelchair counseling techniques to help them to get up over the curbs and the obstacles that they face as grievers. So I didn't mean to get on a soapbox or anything like that, but
you're fine. You explain everything so clearly. And again, you're just your wealth of knowledge. So I am glad that you're on the broadcast to share information, new information to some, particularly their emerging professionals. And for those who've been in the profession a while, it can be new information or it can be a reminder. Because as we're traveling, still navigating through a pandemic, dealing with the mass shootings and other things that are happening in our society, as you said, we're dealing with kind of that collective grief, and some are still traumatized. And so it helps just to remind us how we can navigate through the process and be encouraging of not only the public, but also there are times we have to be encouraging of each other and encouraging other colleagues, because we're doing the work, we're helping other people. But as you mentioned earlier and said it so beautifully, we have to be stewardships of our own trauma and manage and make sure we're coping and living well and trying to be well and practice wellness. So that was beautifully stated. Now, you are the chair for the Advanced Clinical Practice Committee for AMHCA. Share with us kind of the purpose of your committee. What do you do?
Okay, and I would like to credit also Dr. Charmaine Adams, who is a co-chair with me. I've been the chair since I think 2014, and then about a year or two ago, we decided we wanted for her to co-chair and maybe be a chair in waiting, shall we say. And our committee, when I first came on the committee in 2013, we were responsible for anything. I think formerly the title of the committee had been the Committee for Professional Development. And so we were helping with creating and delivering webinars. We had what we called clinical practice briefs, little short papers that could be little quick reads for members. And then we anticipated the year in which we would need to revise the standards. And ultimately, that is our primary purpose, is to kind of monitor the status of the official AMHCA standards for practice. And so the year that the revision came up was, I think, 2017. And it took a long time to revise what existed. And we've been adding some new standards to that we felt were significant to the practice of mental health. I think when Steve Giunta was president, he asked us to add the technology standard, and that's gone through one revision already because of the rapid changing face of technology. We added the standard for working competently with children and youth, for working with older persons. Recently, we added the two standards for working with gender identity clients who have gender identity issues. We all have a gender identity, so that includes all of that, but also the affectional identity. And we did that very, very carefully because of the vast numbers of acronyms and identities and the way that it can be responsibly interpreted. So those are just now, the latter one, the affectional identity, is going to be announced at the national conference in association with Angel's. It's just now getting published, so we thought we would announce it there. So the next few that we're going to add are going to bring us in line with what the credentials committee has. And so there have been a couple, 2 or 3 there that we don't have a standard for, but we want to, because there is a special credential for that. And that would be working with military families, working with couples and families, just in general, and working with persons, particularly youth, who have unique developmental disabilities. And so once we do those, we're going to be kind of caught up for the time, and we'll explore. We're always open to what is emerging, in the field. And there are 3 kinds of categories for standards. One would be a core standard. This is how we have defined it. I'm saying there are 3 categories because we've decided that's the way it would be for our work. A core standard, which would be generalizable to all AMHCA members, all clinical mental health counselors. Another one would be a specialized standard. So one of the ones I forgot to mention was the addition of the forensic evaluation standard, and that would obviously be very specialized. And then the third one would be kind of like an emerging standard. Maybe it's something we're seeing in the field, but it's not quite ready for prime time, still gathering research. Maybe it might make it to a status as a standard, but maybe not, just depending if there was a trend for counselors to do basket weaving. I'm not sure that would make it to the level of a standard, but you never know. So that's the majority of the way that we spend our time. And as we are developing standards, we do our best to find other experts that can contribute to that. And I can't go on without mentioning this, that there's a multicultural and social justice standard that is happening, and that is thanks to you, Beverly, with your promoting that. And where there is some work that's already been done with the credentials committee, so that's good, and we're moving ahead with the standard to be in the official standards document, so that's very exciting.
You have done a lot of work with the Advanced Clinical Practice Committee. You have been with the committee for a long time, and you've just done a lot of work. Your dedication has just been commendable. So again, thank you for your service to AMHCA. Thank you for all that you have done and you continue to do to advance the profession and via AMHCA. So I'm just appreciative of your wealth of knowledge. You're a great resource. And you are serving in your areas of expertise that's definitely needed during these challenging times in a world that's individuals who are anxious and exhibiting grief and mourning and bereavement.
Yeah.
And so thank you for your service.
Yeah, and I would just like to always extend an invitation, where volunteerism is gold. And we've got a few people interested in our new standards that we are, working on now, and they may become part of the committee if they want to, but this is one of the best committees I've ever been engaged in. It's very productive. We really just work together well. It's very generative, even at the personal level for me. And I like being able to be kind of at the frontiers of, what's going at the front line of what's going on with AMHCA. And so thank you for allowing me to share my story and to remain involved.
No, thank you for being involved, and thank you for leading the Advanced Clinical Practice Committee. Again, you've just done a great work. I remember when I joined the committee, you were the chair, and you always embraced me, my ideas, and made space for my voice on the committee. And that I appreciate that and respect, again, your leadership. So thank you for your leadership as being the chair.
Thank you.
The Advanced Clinical Practice Committee. As we begin to close out this broadcast of perspective, is there anything else, any final closing words you would like to share with AMHCA members or just the general community and our audience at large?
Well, my first thought is what kind of gets me through the day. It's been a very, very, very difficult world in all areas, it seems, for the last several years. And I pretend to know those people in Ukraine. I pretend to know those people across the country that I will never meet that are affected by another tragedy. And so, what I guess as a part of post-traumatic, as trauma stewardship, and also post-traumatic resilience or post-traumatic growth, which is another concept related to all of this, is never ever stop believing in hope. Never ever stop believing that one person can make a difference. And that is true. I have to turn to some of those types of almost like a belief, a belief, a faith in humanity that we're going to get through this, and we need more of us than, the other type. So I don't know. I just, I love my husband. My husband supports me immensely, but he will never know exactly what it's like to be in the room with human suffering, like the way I know he has his work, and I don't understand that. But mental health professionals, I think of, are people who go where angels fear to tread, and we just need each other. And we will get through this somehow. So I guess that's my message of hope for today, and that we all take good care of ourselves and make a difference the next day and the next day.
Thank you for that. And so we encourage everyone to hold out hope that it gets better, it can get better, and that keep looking forward to the next day, put one foot in front of the other. Thank you again, Dr. Harrington, for being a guest on our broadcast called Perspective. We are glad that you took time out to spend just some moments and minutes with us. Thank you again.
Thank you so much, Dr. Smith. Take good care.
Thank you for joining the American Mental Health Counselors Association podcast with President and Interim CEO/ED, Dr. Beverly Smith. We hope you will join us for the next episode to connect and hear the perspectives from experts and the organization that exclusively represent clinical mental health counselors. Be well.